Welcome to this Clinical Skills mini lecture, part 1, about the consultation structure. So as we know, every building needs to have a good structure. It's really important to have good foundations so that a building can be built strong, it won't fall down, and it remains well and secure. And the same is for the medical consultation. We need to have a good structure to how we conduct a medical consultation and to build really good foundations in at the start of our consultation. So we teach using the Calgary-Cambridge framework for consultation skills. So this is a framework device that shows a structure to how we do the consultation. We start the session, we then gather more information, we do a physical examination, explain the diagnosis and plan what the treatment will be with the patient and close the session. Now, all through this time, we are providing structure. And this means we need to use some specific consultation skills, communication skills, to help provide that structure. One of these is called signposting, which we'll talk in the communication skills lecture about, which is making it overt. Where are we going in the consultation? What will be the next steps? We also want to attend to timing and the flow of the consultation so that we don't overrun, so that we don't have a big clinic waiting room with lots of patients waiting for their turn because we're taking too long with each patient. And we also want to use skills such as screening at the start of the consultation. So that's checking what are the symptoms a patient has so that they don't get to the end of the consultation and say, oh, doctor, also my knee is hurting me really badly. And then you have to start all over again. So we want to talk about providing a really good structure to the consultation. And of course, during this, we're always building the relationship with our patient. So medical consultations use a common set of structures. We usually start with introductions. We then find out the main presenting complaint or complaints, the main problem the patients come with. We found out the history of the presenting complaint. So that means the story of their problems. We want to find out their perspective. How is this affecting them? We want to find out about their health in the past. We want to find out about their family's health in the past, called family history. We want to find out if they're taking any medicines, if they have any allergies, and then more about their social life, their social history. So as we said, we need really good foundations, and good beginnings to the consultation give us good foundations. We sometimes call it the golden minutes. Those first few minutes when we meet the patient can really help to build rapport and relationship with the patient, and that can help build the rest of the consultation. During the first few minutes, you can gather a lot of information that can help you to make the correct diagnosis. So at the start, it's very important to greet the patient. Tell them who you are. So, hello, I'm Dr. Catherine Miles. Can I just check you're Mr. Mohammed? Check the patient's name, check that you've got the right patient. And then you want to demonstrate respect for the patient, attend to their physical comfort, let them sit down, show interest in them. It's important to start with a really good opening question to find out after you've done those introductions. And there are many different questions you could use. For example, how can I help you today? Tell me why you've come to see me today. So over to you. What's been the problems for you? Why have you come to clinic today? You could say nothing at all and just go like this with your body language to show you want the patient to talk. It is most effective if you let the patient talk, because you're finding out important information about what's wrong with them. They are the expert, they're the ones experiencing these problems, so let them talk. What do you think is the percentage of diagnoses that are made just from listening to the patient, just from the consultation? What percentage of correct diagnosis are made? Out of 100%, how much of the diagnosis is actually made from the consultation? Well, research has showed by Dr. Frankel that 80% of a diagnosis can be made by taking a careful history. But problems can occur right from the start of the consultation. So, for example, doctors often interrupt their patients. Can you guess what the average interruption time is? How long do doctors let their patient talk until they interrupt them? Well, research shows the average is only 18 seconds. 18 seconds that the patient talks and then the doctor interrupts. What about allowing the patient to finish their first opening statement? They found that only 23% of patients were able to finish that first opening statement about why they come to the doctor. And then the doctor interrupted after the patients told them about one problem, their first complaint, about 2/3 of the time. So that was 34 consultations out of 51 consultations from the research. And one of the problems with this is that doctors assume the first problem that the patient comes and talks about is the main problem. But actually, they found out that the order of complaints or problems is not actually the clinical importance. Patients might talk about something first, like saying, oh, I've had a bit of a headache, doctor, and I've been feeling tired. But actually, the main problem is they've got chest pain on exercise. And that's more clinically important than just having a headache. So we can start the consultation with a good foundation, with having good introductions, letting the patient talk, using a nice opening question. A slightly different way to start the consultation is to find out more information specifically about the patient, and this is called the patient's profile. Personally, I don't recommend doing this right at the start of the consultation because you use a lot of closed questions, which doesn't help to build the relationship and the rapport with the patient. However, it is a technique that can be used, and I think it is mentioned in MacLeod. So we have our patient in front of us. We want to find out their name. So what is your name? What is your age? Obviously, certain diseases are more prevalent at certain ages. What is your gender? Usually we won't ask this, it's obvious, but that's part of the patient profile. What is their occupation? What job do you do? And you want to find out specifically what they do, because, for example, if somebody works in a cement factory and they work as an administrative person, a secretary in an office, they're not coming into contact with the cement dust. But if they work in a cement factory on the factory floor, they may be breathing in that cement dust, which would affect their lungs. So there are a number of occupational diseases, and it's very important to know exactly what somebody's job is. Now, you could ask it here in the patient profile, but it comes again, if you haven't asked it here, in the social history. And then also, what is your marital status? Are you married? Do you have children? It can be helpful to know who is at home with the patient. But as you can tell, if you follow this type of opening to the consultation, I would say, hello, my name's Dr. Catherine Miles. What's your name? How old are you? Do you work? What is your job? Where do you work? What specifically do you do? Are you married? Do you have children? Who else is at home with you? So that's a very closed question, direct way of starting the consultation, to then go, and why have you come to see me today? Instead, I would recommend that you start by saying, hello, I'm Dr. Catherine Miles. Can you tell me your name, or can I check your Mr. Whoever if you're expecting a specific patient? Please come in, sit down. So tell me about what's been happening for you. Why have you come today? And then I let the patient talk, and I don't interrupt, and I listen. When the patient has finished talking about the initial things, then I can move on. So we've talked about introductions and using the patient's profile. and then onto the presenting complaint. So as we let the patient talk, they will tell us the symptoms that they've been having. And as we said, it can be more than one specific symptom. There can be a number of symptoms, and we need to know which is the most clinically important. So we want to use certain skills as we're finding out the symptoms. Screening is a skill where we ask, is there anything else, to check if there's any other symptoms. We listen, as we said, we want to not interrupt, and also we set the agenda with the patient. So you've told me about these 3 problems today. I don't think we'll have time to talk about all of them. Is it okay if we discuss this one today? Is that okay with you? Do you have a different preference? Deciding on which problem to focus on. After we've found the main problems, we want to find out the story of these, the history of the presenting complaints, what has been happening. And it's important to find out a good timeline and the order of events. So the skills that we use whilst we're finding out the story of events is things like open to closed questions. So as I said, starting with very open questions. Why have you come today? Then narrowing it down to, where is the pain? When exactly did it start? We want to use active listening, clarification, making sure we really understand what the patient's saying, summarizing, repeating back to the patient, and picking up cues. Noticing verbal or non-verbal cues. So for symptoms, especially if it's pain, we can use the mnemonic called Socrates. Now this is for asking about pain, not other symptoms. And the real skill is not asking a question that the patient has already answered. So if the patient has already told you where the pain is and when it starts and what it feels like and what makes it better or worse, we don't want to then say, so when did the pain start? Where is it exactly? Because they've already told you. So this mnemonic Socrates starts with the site. Where exactly is the pain? O is for onset. When did the pain start? C is for character. What does it feel like? Is it sharp like a knife? Is it a dull ache? Is it a burning? R is for radiation. So you want to ask the patient, does the pain move anywhere else? So radiation means, does the pain go someplace else? For example, if you have pain from a gallbladder, then it can be on the right-hand side of the body, just under the rib cage, but it can radiate. The pain can also be felt in the shoulder. So radiation is a medical word, don't use it with patients, but you can ask them, does the pain move anywhere else? Do you feel the pain somewhere else? A is for associated symptoms. Are there other symptoms such as a fever or vomiting or nausea or sweating that come with the pain? T is for timing. So this means, how is the time course of the pain? Does it come and go in waves? Is it constant? Is it worse at night or in the daytime? Is there some pattern to the pain? E is the exacerbating and relieving factors. So exacerbating means what makes the pain worse. Relieving means what makes the pain better. So you want to ask the patient, does anything make the pain better or worse? And then S is for severity. Severity, we need to tell the patient on a scale of 1 to 10, where 1 is no pain and 10 is lots of pain, how do you rate your pain? Where would you put it on that scale? So you can't just say to the patient, how do you rate your pain out of 10? They need to know 10 is the worst pain, 1 is the least pain. And this can give you a pattern. Now, my experience of pain will be different to your experience of pain. But for me, if I say my pain is 8 out of 10, and then you give me a painkiller, and you come back and you say, how is the pain now? And I say, oh, now it's only 3 out of 10. You know that that pain relief has had an effect. So it's a helpful scale to compare for that patient. And please remember, Socrates is only helpful for pain. If a patient has other symptoms, then you will need to learn other questions to ask about those systems. And as you go through your different specific symptoms like cardiovascular, respiratory, gastrointestinal, you will learn other questions to ask. A great phrase to remember is to say to the patient, "Tell me more." So if they say, "I've got vomiting and diarrhea," tell me more about that. You cannot ask these Socrates questions for vomiting, but you can say, "Tell me more," to encourage the patient to tell you more about their symptoms. So today, in this mini lecture, we've looked at introductions, the presenting complaints, the history of presenting complaints. And then in part 2, we'll continue to look at the next part of the structure, which is the patient's perspective, the past medical and surgical history, family history, drug history analogy, and social history. So I hope you can start to put these steps in order as you will talk with patients. These are the references from today, and I hope you will see that it's important to have a really good structure to the consultation to be able to lead you through it effectively and efficiently. Thank you so much.